You ready?
Yeah.
All right.
All right.
Well, good morning, everyone. Thank you so much for showing up to our very early presentation today. My name is Allison,
And I'm Erin.
and we are speaking to you this morning about critiquing primary literature. More specifically, we're going to be going through sort of an approach to Journal Club. These are our disclosures.
We have none. So to try to make this technologically interactive, we're going to use Slido. So what you can do, and unfortunately Slido is built into the PowerPoint, but it's not working because of course we're at a conference, it's not going to work. So if you go on your mobile device and you go to slido.com, you can enter in the Slido number 386-2430. And we're going to do a couple polls and quizzes because, you know, why not test people's knowledge at 8 a.m. Seems fair. All righty. Give you guys a minute to get, and online too. We'd love you to participate. Are we good? Not yet. Okay. All right. So for our first question from Slido, and you can, now it's my turn to run this live poll. Do you attend Journal Club? And if so, do you feel well prepared for Journal Club? So your answers could be yes and yes, yes, and I'm a bit comfortable, yes, and I have no idea what I'm doing, or no. So if you can put in your answer, oh, there we go. It's working.
It is working.
I'm always so shocked when it works. You guys can't see it, but right now we have lots of no's, a couple of yes, and I have no idea what I'm doing. A yes, and I'm a bit comfortable. Perfect. So hopefully after this presentation, people will be a little more comfortable, but yeah.
Yes.
Oh, yes, we can. How do, oh, was this to go back? There you go. So in general, we have a lot of no, we don't attend journal clubs. And that's honestly why Alice and I did this presentation, because working now, I work in a hospital-based PA role, and they were like, you have to go to and participate in journal clubs. I'm like, what is that? Sure. So this was a nice refresher. All right. So yes, most people do not, 50% do not attend. Some people are a bit comfortable. Some people don't know what they're doing. So thanks for participating, everybody. So next slide. Yeah, so the objectives of this talk is to help people become more comfortable in critiquing primary literature, have kind of a system, you know, how to do this and to be more prepared for journal club. So our objectives are as follows. We want to understand key terms and components of a research study, identify strengths and limitations of an article or study, identify whether the conclusions are strong and can be accepted, and feel prepared for journal club.
We felt it was fairly important to let you know what we will not be doing today. So this is not going to be a full review of biostatistics. Unfortunately, we don't have the time for that, and two, I don't feel necessarily comfortable with that. That being said, we are going to review some key terms, as Erin mentioned, just to make sure everyone is on the same page before we get into the actual critiquing process. I did want to also encourage you that if this is a topic that is of interest to you, there is lots of ways that you can dive deeper. So it does take time to become skilled at reviewing and critiquing literature. Please practice. That's the only way you're really going to get better at it, is, you know, exposing yourself to as much as you can. So first and foremost, let's dive into some terminology. So we're going to be going through, again, some key terms, things like p-values, statistical significance, confidence intervals, hazard ratios, number needed to treat, and then we're going to have a bit of a discussion about the differences between absolute and relative risk.
We broke it.
We broke it.
Next slide. Well, the next slide is actually with using your Slido, because what's not on here? Let me see, is it? Oh.
And we broke all the technology.
Everything's broken now.
Christy, can you advance our slide? Is that possible?
Oh, there we go.
Hey, okay.
So this, of course, no, there we go. It is working. Is it working anywhere? So the question is, what is the p-value? If you look on your slide, can one of you tell me if it's actually working? No?
It just says it's working.
Okay. So we
P-value.
have, of course, it's not on here. The definition of a p-value. Do you want to we'll just move on instead of using this as a poll. This is broken. Christy, can we get you to advance the slide? I'm sorry. Ours is broken.
We're starting off strong, everybody.
Sorry. Next. Thank you.
Is it working now?
Just stop. Hey, okay. So we're going to forgo the poll on that one because our slide was not working. So the p-value tells us the probability that the effect that we're seeing within a given study is a false positive. In other words, we can ask, what is the probability of rejecting the null hypothesis when it is in fact true? That the effect of our treatment was not the true effect. We have to remember the default position in any study is that the null hypothesis is true, that there's no effect between each of the groups. So if we can kind of put this into practice, the higher the p-value, the greater the chance that the effect that you're seeing is not real, meaning that the results are due to noise or chance. The lower the p-value, the greater the probability that that effect that you're seeing is in fact real. It's due to whatever intervention you are testing. So for example, if the p-value is 0.19, that means there's a 19% chance that the effect that you're seeing is actually a false positive. So we want p-values to be as low as possible. They can never be zero. There is always the possibility or probability that part of this is due to chance, but we want that to be as small as possible. So what about statistical significance? So we say that there's statistical significance when the p-value is less than 0.05, meaning there's a 5% chance that these results may be due to chance, noise, etc. And that's deemed an acceptable level, essentially. If the p-value is above that, we say the results are not statistically significant, and we accept the null hypothesis.
Beautiful. Next slide, please. Confidence intervals. So the definition of a confidence interval, it is the probability that the data that we've collected in our study will fall in between a set of values or a range, and that we can be confident that when other people reproduce our study in the way that we've set it up, that they will also fall within that range. So basically, how confident are we in the data we've collected? It's going to be between two measures. So for an example, if I wanted to create a confidence interval, I'm going to be studying women ages 35 to 50 and treat them for urinary tract infection symptoms with fosfomycin. I want to know how many days on average is it going to take to resolve those symptoms. So I'm going to take my 100 women, treat them with fosfomycin for their UTI symptoms, and get a mean or an average number. Most women are going to be have resolution of their symptoms in 4 days. I take that one mean. I then repeat this 50 to 100 times and get all of those values. Those are going to make up my confidence interval. With a 95% confidence interval, I'm 95% certain that if you do this study or if you treat a person with fosfomycin for UTI, they're going to have a resolution of their symptoms between 2.92 or 3 days or 5.62 or 6 days. And that on average, it's going to take 4 days. And then with a 95% confidence interval, my outliers are 2.5 on each side to make up 100%. A 95% confidence interval is normally accepted. With very, very large scale studies, you can get a much higher confidence level, upwards of 99. But again, you need a very, very large population to study to be more accurate in that. We're more confident in that and those numbers. Small scale studies often have a much lower confidence interval because there's more variability. Next slide, please. Hazard ratios. So hazard ratios are looking at comparing the probability that an event, a hazard, an intervention or effect is going to happen in a test group versus the probability that that same effect, hazard, whatever we're doing in the control group at one period of time. So oftentimes we use hazard ratios to describe cure rates with a drug in our test patients versus controls, and they're represented in a numerical form. So a hazard ratio of 2 means that in my test group, they are twice as likely to experience that effect compared to the, test versus control group. A hazard ratio of half or 0.5 means that my test group is half as likely to have that effect compared to the control. So why do we care about hazard ratios? We use them a lot in survival analysis. We use them when we're looking for cure rates with different treatments and drugs. We'd like them for looking at incidence of death. Hazard ratios can be really helpful at looking at impacts, but you cannot use a hazard ratio on its own. Yeah, there we go. Yeah, thank you. So hazard ratios are used for creating other more meaningful things, but you cannot report it. So now next slide. So an example of this is a CNN reported that eating chilies is going to reduce cardiovascular risk. So, and this was in 2019, many different sources were like, eat chilies every day. This is going to help you overall risk. And they were actually basing this off of the hazard ratio. They felt that it was by 34% that you could reduce your risk. But again, what does this mean? Like, what are we actually comparing here? So in order to make a hazard ratio meaningful, you need to know what's the study size, how many actual fatalities happened in our test group for eating chilies, 4 times a week versus the control, and how much chili. Are we talking like handfuls? Is it a little sprinkle? We don't know. So again, with these reportings of hazard ratios, it's not meaningful. Next slide, please. Next is number needed to treat. So this one a little easier to define because it's as it sounds. So we are looking at how many people need to be given a certain treatment or intervention to have a positive or desirable outcome. So number needed to treat, we often use this when we're looking at like therapeutic interventions or medications. And it's specifying the treatment itself, its duration, and the adverse outcomes being prevented. So I'm going to use a silly example. So if we're looking at the number needed to treat for a parachuter, we can confidently say, if you're going to jump out of a plane and I give you a parachute, you're probably going to survive. If I give you the right education on it and it's a beautiful parachute, it's going to work. We can also argue that if you jump out of a plane, you might actually survive as well. But with this example, if I give you one person a parachute and they jump out of a plane and they survive, my number needed to treat is 1. Not the greatest example, but I thought it was funny. So there we go. A lot of times we use this with actual risk calculators. A really popular one that I liked in family medicine was your CVD risk calculator. So this is looking at statins. So the research has shown that using a statin will help reduce your fatalities and coronary events, and the number needed to treat is 20. So again, I have to treat 20 people to save 1 life essentially, or avoid a fatal or potentially fatal outcome. Next slide, please.
All right, so I'm going to take over now, and we're going to start with a bit of a example. So you can see this is not a true scientific study. This is an article based on a study from marthastewart.com that says, good news, science says that eating chocolate really does reduce your risk of heart disease. During a follow-up about 3.6 years after the start of the study, researchers concluded that cocoa extract reduced cardiovascular death by 27%. So I'm going to pose this to all of you who are here with us today. What are your initial thoughts on this? Is there any sort of alarm bells that come up? That's a good one to start with. Yeah.
She's very reliable.
Anything else?
I'm going to eat more chocolate and chilies,
Apparently. So you can kind of keep that in mind. Yeah, exactly. Okay. So can we go to the next slide, please? So further on in this article, it stated, despite these positive findings, the researchers note that the supplement did not significantly reduce cardiovascular events among older adults, and that further research is needed to clarify whether cocoa extract may reduce clinical heart-related events. This seems a little bit unusual because our initial headline said there was reduction in cardiovascular death by 27%, which is a fairly decent percentage. And now they're saying there's no significant differences. So why might we see that? A little bit. Okay. Next slide, please. So this is all about risk and reporting risk. So we've got a couple definitions that we'll go through here. So in the top left-hand side, you can see our absolute risk. And this is simply the number of events that have occurred in a certain group. So either your control or your experimental group over the period of time. On the bottom left-hand side, you can see absolute risk reduction. So this is the difference between those event risks in your control group and your experimental group. So on the top right-hand side, this is where things get a little hairy. We have the relative risk, which is the ratio of that probability of an outcome in the experimental group to the probability of the outcome in the control group. And where things get really hairy is our relative risk reduction. So this is the difference in those same event rates between the two groups, except it's expressed as a proportion of the event rate of the control group. So why is this a problem? This exaggerates the therapeutic effect of any particular intervention. So we can go to the next slide. So let's go back to our study and actually dissect this a little bit. So this was a study that was started in 2016 by a researcher named Sesso and his sort of a group of associated researchers. There was 21,442 participants in this randomized controlled trial that was evaluating the effect of cocoa extract on atherosclerotic cardiovascular disease. Subjects were randomly assigned to receive either cocoflavanols at 500 milligrams per day or a placebo. The investigators evaluated the number of cardiac events, including MIs, strokes, cardiovascular death, and carotid artery surgeries. So let's do the math on this a little bit. So in our placebo group, there was 104 cardiovascular deaths in a group size of 10,719. So that gives us an absolute risk of 0.97%. In our experimental group, or our cocoa extract group, there was 76 cardiovascular deaths in a group of 10,723. Our absolute risk is 0.71. So our absolute risk reduction is simply the difference between those. It's 0.26%. So the 0.97 minus 0.71 makes sense. But when we start to look at relative risk, again, we're looking at that same difference in event rate as a proportion of the event rate in the control group. And that's where we get our 27%. This is really significant because really, there was a very little difference in the number of deaths actually seen. In the entire study, looking at cardiovascular death, so in a population size, global population size there, of over 21,000 participants, there's only a difference of 28 deaths. But that's still 27%. So the other important thing to note is in the actual study, when you read it, the absolute risk is not identified, even in the discussion. They only report the relative risk reduction. And 27% looks a heck of a lot better than 0.26% reduction. So reporting relative risk on its own is incredibly inappropriate and very misleading for readers. So something just to kind of pay attention to when we're starting to see things like that. We can go to the next slide. So now that we've gone through some of these definitions, we're going to start to apply this when it comes to approaching a journal club. Next slide. So we're going to start with what we call the 5 W's of primary literature. So we can look at why was a study completed? What was the motivation for it? We can look at who was involved, who are the investigators, who are the participants, who funded the study. We can look at when it happened, when did it take place, how long did it last for, where did it happen, what was the setting, what was the type of study that was completed, and then what happened. What does it mean to you? What does it mean to your practice? Can you even use these results, or is it really not important to you at all? Next slide. So let's go back to our COCO study once more here. So the why. What wasn't reported on that Martha Stewart article as well was there was actually an additional arm to the study. So it was to determine if dietary supplements of cocoa extracts or multivitamins reduce the risk of cardiovascular disease and cancer among older men and women. So our who, the investigators, as I mentioned, Sesso and his kind of continued group of authors and investigators. The participants, 21,442 US adults. It was women over the age of 64 and men over the age of 59 that had been free of heart attacks, strokes, and any recently diagnosed cancers for the last 2 years. All of the participants were contacted through involvement in different studies. So the Women's Health Initiative Extension Study, the VITAL study. They were also targeted through mass mailings and recruited via the internet through volunteers. Our funding came from the Brigham and Women's Hospital. So hospital-based funding, we like that. It was noted in the study that the two main authors also received investigator-initiated grants from Mars Edge, which is the company that supplied and packaged the cocoa supplements, and as well as from Pfizer, who donated the multivitamins and the packaging for that. The main author also received grants and honoraria and funding for travel to various places to report on the findings of this study. The study started in June 2016, and this branch of it concluded in December 2020. The average duration of participant involvement was 3.6 years. Now, it is also important to note this study is ongoing. The secondary researcher has stepped up as now the primary, and there's going to be more findings that come out from it later. And where? So again, funding came from the Brigham and Women's Hospital in Boston. That was also one of the primary sites, as well as the Fred Hutchinson Cancer Research Center in Seattle. Our setting or experimental design was a 2x2 randomized control trial with 4 arms. So I'm going to pause our little roadmap here and let Erin take over to tell us a little bit more about experimental design.
Next slide, please. So we're going to be looking at the wheres, and I think it's important to kind of review the different types of studies. So typically studies are divided into kind of 3 categories that we're going to explore today. So you have your critical appraisals, experimental studies, and observational studies. So these are arranged in a hierarchical fashion in terms of the quality of evidence, but I will also point out that you have to look at each study individually because not all meta-analysis are more critically appraised and of higher quality of evidence compared to a systematic review. So we'll get into that. Next slide, please. So first we look at the observational studies, and nicely enough, it is as it sounds. Observational studies are when you're observing a patient or groups of patients and there's no intervention. It's just reporting of this. So again, on the hierarchy, they're a little bit lower, but I think there is actually a lot of value in observational studies because it's helping people identify kind of interesting symptoms and can help, lead to diagnosis for patients. So looking at a case report, you're looking at one patient with either a side effect from medication you've never seen before, or they have interesting symptoms. I publish this, and then if more people have patients with similar findings, then you can create a case series. And then from there, larger scale, you get to your cohort studies. So with cohort studies, they're interesting because they can either be retrospective, so looking at things back in time, or prospective, forward in time. So again, on the hierarchy, these are kind of lower in terms of the quality of evidence, but they definitely are helpful in clinical practice. Next slide, please. So now we get on to our experimental studies. So these are the randomized control trials that we love and non-RCTs. So again, when we're kind of distinguishing the two, it's kind of as they sound. When we're taking our study group or a population, randomized control trial is random, non-randomized is not random. We are deliberately picking this group of people to study. Why would we do that? So for instance, if we have a group of poorly controlled diabetics, HbA1c over 9%, and I have a new drug that I want to try with this group and see if it has impact and can help manage their diabetes, I'm not going to randomly pick people from the population because then people like Allison who don't have diabetes are going to be getting this drug. So I'm taking that group of people and then making them into my study. So non-RCTs are very deliberate in how they're picking people. And also it's nice that when you're doing these studies, you're looking at that cause and effect impact, and it's in a controlled environment. And you can also help eliminate a lot of the ethical issues behind some of these studies that you're doing. So again, there is a lot of value in non-randomized controlled trials, but they're very specific and deliberate. So your randomized control trials, of course, are our gold standard. Everyone loves a very good RCT. And why they are important is because, again, you're establishing causation. You're taking, a more representative group of the population and finding the impact of a treatment or of what you're trying to to a study essentially. Also with randomized controlled trials, we like these because there's less chance of bias. There can definitely still be bias, but less than others. Next slide, please. So then we get into the critical appraisals, which I like. That was explained to me. You're looking at the forest for the trees, and the trees are all of these studies that might be looking at the same type of question. What can we make of these? So these are divided into meta-analyses, systematic reviews, and then you kind of get into the critical appraisal evidence-based guidelines, which I'll kind of touch on after. How I found it most helpful when thinking about systematic reviews and meta-analysis is like in your master's and your PhD. Your systematic reviews are your master's degree and your meta-analysis or PhD. If I have a bachelor's, I cannot just go ahead and get a PhD. I can't just jump to doing a meta-analysis. I have to get a master's degree first, doing a systematic review. So every meta-analysis is from systematic review, but not all systematic reviews go on to become a meta-analysis. This made my brain explode at one point, but anyway. So systematic reviews are looking at a very specific, like PICO style question, and they have a very systematic way of how they're choosing the studies to include. It's a really, like, I call it a summary, if you will. So with the systematic reviews, again, they have very specific inclusion, exclusion criteria, and they're also looking at both published and non-published studies. So from that, you have a couple of reviewers that are doing the same thing to, again, make sure that this is reproducible, make sure it's more that anyone could reproduce a study and it's going to have the same results. And then they're really looking at, again, a summary of information. It's not quantitative at all, but again, can ask or can look at some very important questions. And then from there, if one is interested, they can go on to do a meta-analysis. So again, meta-analysis is a quantitative kind of summary. They're looking at a very, very specific question. We call it an ad hoc style because it's one question, one point in time. And they are looking at when they collect these studies that are going to use, they give them weights in terms of how quantitatively they matter, which now that I say it loud, that sometimes they can get a little hairy as well. But for the most part, larger studies with larger sample sizes get more weight than smaller studies. And from this, we can make a statistical summary effect. Now, I will say again, with meta-analysis, you got to be really careful because garbage in is garbage out. If you have a bunch of rinky-dink studies that you're looking at and creating meta-analysis, you're not going to have a good meta-analysis. So something to kind of think about. Oh, and then last but not least, so evidence-based practice guidelines. So these are nice and definitely very applicable for clinical practice because what they're doing is either looking at systematic reviews or sometimes meta-analysis, getting a panel of experts, so multiple people that are, the experts in that area of medicine, and they're coming up with guidelines that are patient-centered and really more applicable. So again, kind of like a summary of an expert summary, we'll say. Next slide.
All right, so back to our little roadmap here. So we left off at our where. Again, our study site was the Brigham and Women's Hospital in Boston, as well as the Fred Hutchinson Cancer Center in Seattle. And we have a 2x2 randomized control trial with 4 arms. So the things being studied, each of the arms were a cocoa extract placebo, a multivitamin, and a multivitamin placebo. Now, what now? What can we do with all of this information? Well, this is where we start to look in the strengths and the weaknesses of a study to truly critique it. Next slide, please. All right, so these are the things that we are going to touch on with regard to our critique today. Certainly not exhaustive, but we're going to look at bias, we're going to look at funding, control, randomization, blinding. As I said, this is not exhaustive. There are many, many different things that we can look at when it comes to research studies. Unfortunately, in the interest of time, we will not be able to touch on things that kind of give, a bit more thought. So things like power, we're going to have to defer for today. Next slide. So first, we're going to touch on bias. So what is bias? In exceptionally vague terms, it is simply the distortion in the measure of an association due to a particular factor or a number of different factors. We're going to talk about 3 different types of bias today in a little bit more detail. Now, again, there are many, many different forms of bias that can come up. But for our purposes, we're going to stick with these 3 today because we tend to see them a little bit more frequently in at least what we're talking about today. So starting with selection bias. So that is the distortion in the measure of an association due to a sample selection that doesn't accurately reflect our target population. So this happens when there's improper procedures in selecting our sample population. So the participants of a study may actually differ systematically from the population that we want to apply these results to. So really, we want the selection of a study population to be exceptionally broad to improve the generalizability. Now, when Aaron was talking about randomized control trial versus a non-randomized control trial, if we're doing an NRCT, it's fine if we use a very specific subset of a population or, very specific inclusion criteria because we are defining that and applying it to a specific population. But if we want those results to be broad, the study population has to be broad as well. So for example, let's say we have a study that's looking at an influenza vaccine and we've picked a group of healthy young adults to test this. This is really only going to be applicable to healthy young adults. It's not necessarily going to translate into findings that we can apply to a population that might be better served with influenza vaccines, like the elderly or people with multiple comorbidities. So therefore, the study is not representative of who we want to apply it to. So that would be selection bias. The next thing is performance bias. So this is when a participant changes their behavior because they're aware that they're being observed. So we tend to see this very, very frequently in things like food log studies, but the sheer nature of logging everything that you're consuming, you're going to change your behavior, and patients change their habits that way. So this is far more prominent in things like observational studies, but it certainly can happen in randomized control trials as well, particularly if a patient finds out or knows that they're in a control arm of a randomized control trial. They may be less compliant with the trial protocol. They may also be more likely to leave the trial early and not provide their outcome data. The other place that we can see this is the level of the involvement of the researchers and investigators themselves. So for example, if you have, let's say, a weight loss study and your treatment arm is a new weight loss medication and your control arm is kind of standards such as eating Canada's food guide, or adhering to Canada's food guide. But with that in your control arm, your participants have access to the investigators, to dietary counseling, that sort of thing. This changes how those participants are going to behave. So if one group is getting more coaching or counseling than another, this can impact the performance of the subjects, even in the control group. So each person in each group should be getting the exact same amount of attention, coaching, and contact with the investigators to limit that bias. Lastly, we're going to talk about recall bias. So again, this is the distortion in the measure of an association, but this is due to a lack of accurate measurement. So this tends to happen when we're looking at studies that involve questionnaires. This is not to say that all questionnaires are inherently biased this way, but it really depends on the question that's being asked and how objective that can be. So for example, if I ask you, how many days did you have a hamburger for dinner in the last year? That's going to be very difficult to answer accurately. But if I look at a group of female patients and ask, how many times did you give birth in the last 10 years? Probably going to get a far more accurate result. So it's just not to say that all of these questionnaires do have this bias. It really depends on how accurately your participants can respond and tailoring your questions that way. So we do have a poll that we're hopeful will work. And it might not, so then we might just move on.
So next slide. Please.
Next slide, please.
So just by reading the title of this article, I'd like you guys to answer what type of bias this is. So a validation of the 7.5% CO2 model of generalized anxiety disorder using paroxetine and lorazepam in healthy volunteers. All right, let's try this out. So if you go to your Slido app. Yes. Okay, let's do it. Yeah, it's
Okay.
working. So you can put in your answers. So what you're trying to determine is a selection bias, performance bias. There we go. Or recall bias. And yes, 100%, it is an example of selection bias because you're getting volunteers. Beautiful. Thanks, everybody. Okay, next slide.
Next slide, please.
The next slide. All right. So then again, when we were doing our critique, we got on to funding. So funding I find very interesting because it makes sense to me that could be a source of bias because funding is the source in the intention behind a study, why they're doing it. And obviously they're going to have a result that they want to get. Now, who funds these studies? I'm a little biased here and I said drug companies mostly, but you can also have hospitals that fund really great studies. Elon Musk could fund his own study if he wanted to. So with this, it's nice that when you're looking at articles and studies, they have to declare where the funding came from. But also when you're going to a journal club or someone's presenting an article, they also must disclose if they received any funding, any honorariums, did they pay for the flights to go to this conference, that sort of thing. So again, when you're looking at papers, funding can be a big source. And the example I like to use too is when you have a paper that has been done and funded by, say, Pfizer, and they're comparing their drug to a competitive drug. So let's say rosuvastatin and simvastatin. Make sure that you look at the controls or the one that they're comparing to aren't actually being given at subtherapeutic doses so that they look like they have the better drug. And next slide, please.
All right, so now we'll talk about control. So the control group in a study simply serves as a comparison group for your experimental treatment. These are individuals who are not going to be exposed to the independent variable. So in practice, in randomized control trials, your control may receive a placebo. They may also receive the treatment standard, similar to what Erin had just mentioned with a, for example, study looking at the treatment of different statins. You could compare one to the other. One is your control theoretically, and one is your experimental. In case control studies, so these would be more observational studies, you will also have controls there. So controls need to be selected very carefully so that they're people who do not have the, for example, disease in question that's under investigation, but they would be included in the study as their cases if they did. So you need to match those two groups very closely. Now, the other thing we can look at is something like crossover trials. What are those? This is when you have an experimental study where the cases also serve as, or the experimental group also serves as their own controls. They're matched to each other. The reason this works is you have two groups and they're receiving both the control as well as the treatment, just in different orders. So this works really nicely because you're limiting a little bit of the bias there. Now, things that you need to be careful about is if you, in your group that is receiving the experimental, for example, drug first, you have to make sure that whatever the effect is seen with that component doesn't bleed over then into the control period that happens after that. So you need to look at, do you need a gap between these two treatments? Does there need to be a washout period? That sort of thing. But this is just a different way to control for different variables in a study.
Next slide. So question, and this is not on Slido, thank goodness. Can you improperly randomize a trial? With show of hands, yes. Yes. And then no, yes, you definitely can inaccurately randomize something. So next slide, please. So the definition of randomization is the process by which we are taking participants in a clinical trial and they are assigned by chance to the separate groups, your control and your treatment groups with the different interventions. We really like randomization because this is really when you have the results from your study, it's a true reflection of like the general population. So it might sound easy just to randomize a study, but it actually is quite a bit more difficult. The example I like to use is that I'm sure everyone remembers when the Mediterranean diet came out and the studies behind it saying that this was going to reduce cardiovascular risk. It was actually a great study that was done between 2003 and 2011 by a group called Pre-Dimed. Anyways, the researchers in Spain took different villages and assigned them to either a low-fat diet or this or the Mediterranean diet. What ended up happening, though, is that within that village, one household would be the Mediterranean diet, and the other household was a low-fat diet. Neighbors started noticing that the Mediterranean diet groups were getting way fresher food. They had more variability, and it just seemed like they were getting the better meals. So then the researchers started noticing people were dropping out and getting pretty angry. So what they had to do is they had to do cluster randomization. An entire village was assigned to the Mediterranean diet or the low-fat diet. And unfortunately, this really clouded I want to say the validity, but the researchers, this was an excellent study, but everyone was very upset because it wasn't true randomization. But again, you have to think practically. If I'm in a household and myself and my daughter are eating one diet and my husband's not, it's not going to work. You're not going to have good compliance with that. So randomization it sounds lovely, but you have to be very careful when you're doing it. Next slide.
All right, so we're going to talk a little bit about blinding, and this is simply the process by which those involved in this study are unaware of which participants are receiving which treatment. So either like treatment or control or whatever the sort of opposing option is there. This is important because there is an inherent risk that expectation can influence the findings, leading to a biased result. And the bias that's associated with knowing the treatment is often quite subconscious. So we can look at different styles of blinding. It's important to note that blinding is not an all or nothing thing. We can actually blind most or many of the involved groups in studies. So this isn't just the investigators and the participants. This can include the clinicians that are involved with the care of the participants. This can include the data collectors, the outcome adjudicators, as well as the data analysts. So some terms that you might hear, something like double-blinded. Now, again, that tends to come up as researcher or investigator and participant. But again, we do want to blind as many people as possible to reduce the amount of bias. You can have single blinded studies where the participants are blinded, but the researchers are not. And we can have open studies or non-blinded studies. And sometimes we simply can't blind our studies. That makes sense. So for example, exercise studies, if you're testing different types of cardiovascular exercise, if you have one group doing intervals and one group doing steady state cardio, everyone knows what group they're in. That's still okay. We just have to be aware of that and look at the analytics that way. Another thing that's come up is there's more research going into the effect of psychedelics. It's really difficult to blind someone if one group has a really robust psychological effect with a medication and one group doesn't. Again, you just have to be aware of that. So what happens if we don't blind our studies? Well, randomized control trials that are not blinded typically show larger treatment effects than those that are. So we just have to be aware that there is that bias there. Now, blinding participants to a treatment they've received is especially important when the results are subjective. So if we're asking patients to rate, the amount of pain that was alleviated with a certain medication, treatment, that sort of thing, it is really, really important that they are blinded. If it's a bit more of an objective finding, such as death, blindings may be a little bit, I don't want to say less important, but maybe doesn't need that level of strength. We can go to the next slide.
All right, so now we've done our 5 W's for a study. We've looked at how to kind of critique and where we can pick things apart. So now what do we conclude? What is this study actually telling us? Let's look at the results. Are the results valid? Was the math done appropriately? Are they reporting all of the different numbers, again, in a way that's meaningful? Do we care? With this study, it could be great, but do I actually care about the results? Am I going to use these in my life with my patients and in clinical practice? And if I don't care, can I learn something from this? If it was not a well-done study, does that mean that we can actually take some of these principles and go on to do more research? Or if I really like this study, maybe I want to do more research. So again, when you're looking at journal clubs, we care a lot about the critique and the conclusions, because again, does this matter? Next slide, please. So now we're going to review all of our concepts that we've learned today. Next slide.
All right, so we first started with the 5 W's of primary literature. So our why was the study done? Who was involved? Who were the investigators? Who were the participants who funded the study? When did it happen? How long did it last? Where did it happen? What setting was it in? What type of study was this? And what happened?
Yeah, so again, when you're presenting for Journal Club, we really care most about the critique and the conclusion. So when you're presenting this, go through your 5 W's. Do not read the entire article. Don't like that. And really the critique, let's dissect this. Is there areas of bias? Was there proper randomization? Who funded this study? And again, what could have been done differently, or what matters? Then make our conclusion. This is where you get the fun banter with people, and people get very excitable about, again, is this a good study? Can we accept this study? Is there things that are meaningful to change our practice or help influence how we practice medicine? So again, when you're looking at it, those are the 2 big ones. Next slide. So now that hopefully you have a better approach to Journal Club, there's a few tips, and I hate to even have to talk with this first one. Please dress the part. Even if you're on Zoom, top up needs to look nice. Because again, if you're like, it's amazing how many people still do not come prepared. Look like you know what you're doing, right? Dress to impress. Do not rehash the whole study. You can read. People, hopefully, who are joining your Journal Club can also read. They should have read it, and so should have you. So if you're rehashing the entire study, it just makes it look like you didn't read the study yourself, or maybe don't understand it. Again, focus on the critique and conclusion. This is what we really care about. This is where you get your banter. And what I always found helpful with this is there are a lot of amazing study tools that literally check box as you're reading your article that can help keep you like succinct and honest in your actual appraisal or a critique of your study. The one I did like the most was for University of Calgary. Has some really great websites for that, and the tools are great. And also tools can be helpful because how I critique a qualitative study is going to be different than a quantitative study. So there's lots of tools out here to help us do that. And know your audience. So with this, I mean, if I'm critiquing a article, let's say a foot and ankle orthopedic journal, and at my Journal Club, my 2 orthopedic surgeons who do foot and ankle are there, maybe I should know if one of them actually was involved with the study. And that might change how I critique it or how I keep my job. So know your audience. And it's, again, has come up, which is interesting. And again, but knowing your audience too can allow you to be either better prepared or kind of know how deep we're going to go into this. How much are they going to know about the study as well? So next slide. So the last but not least, and I don't even know if this is going to work, but hopefully after this presentation, we're hoping that people feel a little more prepared for their journal clubs. But the question would be, do you attend Journal Club? And if so, do you feel well prepared? Let's see if this works. Stand by. Here we go. Play. Okay. It's working. You also don't have to answer. That's cool too. Oh, there we go. Okay, so some better. Yes, I'm a bit more comfortable now. That's great. No, but I feel I can maybe do it now. Perfect. Again, this is just a helpful tool. So thanks, everybody. Next slide.
All right.
Beautiful. Does anyone have any questions? If not, there's a funny cartoon to spend some time reading. Excellent. Next slide, please. We'd like to acknowledge our team today. Excellent. Thanks, everybody.